it may be 90 days, it may be 180 days, but if you can, call your rep and say, I've got these 3 products that have 180 days worth of use. I know I'm likely not going to use them. Can we swap them out? They are, I think, far more willing to do that. It's a collaboration at that point and allows them to not waste something that could be used. And so, definitely, I think that is a conversation that's happening more and more.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
I'm Justin Poulin, and this is Power Supply. Today, we are speaking with Christina Tosto, Vice President and General Manager for WaveMark Clinical Supply Chain Solutions at Cardinal Health. Hayes, I think you know Christina pretty well because she was at your meetings last week.
She was. She's fantastic. Yeah, she came to the Council Supply Chain Executives meeting last week, so it was fun to see her there and her team, and now see her here. And we're going to talk about a bunch of things with her expertise. And so come along, join, and I think you're going to have a great time.
Yeah, I think this will be an excellent interview. We're going to be talking about waste, the impact on patient care. We'll even talk about environmental consequences and sustainability. So that is definitely a topic that is getting more and more attention these days. And Hayes, I'm sure it came up at your meetings last week. And I'm just going to give you a plug. Just here we go. If anybody doesn't know what we're talking about, and you really should, if you're already following Hayes on LinkedIn, definitely connect with him and send him a message, and he could tell you a lot more about the council work that he's doing. We're going to be right back with Christina Tosto.
Bam! I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
We are speaking now with Christina Tosto, Vice President and General Manager for WaveMark Clinical Supply Chain Solutions at Cardinal Health. And Christina, I know you and our friend Hayes here got a chance to be in person last week, but we're really excited to talk to you today as well. And I'm sure you covered a lot of these topics at that meeting, but really talking about medical supply waste and really how this just impacts healthcare on multiple levels, including patient care, costs that are associated with that care, and also just general performance and our ability under what I would say is pretty tight constraints these days, financially and operationally, for a number of different factors. So thank you so much for coming on the Power Supply podcast today.
Thank you very much for having me. I'm very excited to talk about this. This is extremely relevant and a very, I think, important topic for us to dive into and understand better.
So why don't you give everybody just some background on yourself? And honestly, tell us how you know Hayes, because everybody wants to know, and any stories that you have about him would be
that's great.
Also appreciated.
No, I'm sorry, she's got to go. This was great, but we're going to have to jump to something else.
And you will have to edit this one out. But, there always seems to be somewhere in our meetings, Hayes, that comes up about someone always asks you if this particular individual might have been your girlfriend in a previous life. And you look around the room and you say, okay, my wife's not here, but no, she wasn't. You always have a story. It's a really great story. And then someone will ask, did you date that person once? And you're like, well, my wife's not here, but I didn't date her.
No, I did not.
Christine, I have to ask you, though, like when you first met Hayes in person, did you think he was a little taller than you expected?
Actually, no, but see, you guys haven't met me in person. So what you probably don't realize is that I'm extremely short.
Short.
Yes. And even a lot of people who know me personally don't realize how short I am until I actually show up in flats or a pair of like regular sneakers because I'm always wearing heels. So what I learned through COVID and this virtual reality here is you never know how tall somebody is. Ever.
Agreed.
Yeah.
I mean, I met Justin for the first time about maybe a year ago. Heck, I mean, he's not even 5'3" or 4. I think I was shocked. I mean, I was just looking over him. I was, I finally saw him.
He was scanning the room and he didn't see me.
I felt somebody like tug at the bottom of my coat. I went, "Oh, there you are."
Oh, he just turned on you.
I'm not that short, but I am definitely not clearing 6 foot like you two. So, Christina, tell us about your background.
Sure.
What's your experience in supply chain?
Great. So I've always actually been in supply chain from the very beginning of my career. I went to school for public health administration. And when I first came out with my master's degree, there wasn't a really good fit, I didn't feel like, for me in the industry and in healthcare. And so my first job for a few years was with the state ports. And so I worked in containerized cargo and really learned a lot around what supply chain was at a time when most people didn't even have an appreciation for how we got our day-to-day just essentials. So I spent a few years in there, and after a few years, I did a little self-reflection and made a decision that if either I was going to use the education that I'd spent the years to invest in, or I wasn't. It was kind of like that inflection point in your career. And at the time, there was an opening at a hospital in my local town in Wilmington, North Carolina. And so I applied for that. It was in the pharmacy, actually, as a business manager. As part of that role, I actually joined Cardinal Health, who was the pharmacy management solution at the time for the hospital pharmacy. So at the same time I came into healthcare, I joined Cardinal Health, and that was about 17 years ago. So I've been with Cardinal for 17 years. The first 7 of those 17 were in the pharma space and supporting the pharma business. I also got my black belt certification in that time period. And coming out of my certification with my black belt was the same time that Cardinal acquired WaveMark. And there's a lot of very strong connections between the way that we think about inventory management in WaveMark and like Kanban, for example, and lean thinking. And so it was a natural progression for me to move into the WaveMark team. And I came in as an operator, really. How do we implement? How do we learn the problems and issues and challenges that our customers are trying to solve, and continue to iterate on what we saw as an end-to-end solution to continue in that evolution of changing with the industry and with our customers. And so I've spent the majority of my time, even prior to this role, which I've been in just about a year, with our customers, sort of, I would say, in the trenches, really shadowing, listening, learning, and then taking what I hear back to our team and really brainstorming and looking for ways to stay relevant and innovate on what we can do to continue to be a partner and help solve those challenges because they're changing.
Well, I love that you're in the trenches, so to speak, because I feel like that means you're going to give us lots of detail and takeaways today based on your experience. And, I think I want to start with just like medical supply waste. Let's define it in the context of our conversation today, and then maybe we can go to cost implications from there.
I think for medical supply waste, in the context of the conversations and the challenges that I hear from our customers, it really comes into what I would categorize as probably 3 distinct buckets. The first is you have waste of things that you purchase but truly get trashed. They get opened for a procedure but not used and just thrown into the trash because they're single use, sterile, whatever, but truly just open and not used. The next category I would say is waste that we see that manifests through expiration. So we have purchased what quantity of product more than we needed. We did not use it in the time frame in which it was still within its viable use. And so we have no other option but to expire that product. Huge issue. And then thirdly, I would say is what happens with obsolescence. And so you have products that you purchase because you have a practitioner or a physician who prefers a particular product. Now, either one of two things happen. Either they leave and go to some other institution and no other practitioner is actually going to use that product at the same velocity. And so it becomes obsolete. Or, we're in an innovative time in the, just the industry in general. And so new products come on the market and the practitioners want to use the newest product available. And so as iterations come out of new products, the old versions don't get completely used before the new versions hit the shelf. So that's what I see and what I hear in product waste: thrown away, expired, or obsolete.
How much money do you think, and I don't want to mean this on a national scale necessarily, but take maybe an average sized hospital. You don't even have to do it at the system level unless that's easier. But how much waste are we talking about? Quantifiable, because we're all trying to find ways to reduce, costs in healthcare. Waste is one of those that has no impact necessarily on patient care from the standpoint of if you're not using the product anymore or you can't use it, it's not going to disrupt the operation. It has other ancillary impacts, which we'll dive into in a minute. But from a cost structure, how much waste are we talking about that's hitting an average sized hospital, maybe 300 to 500 beds?
Right. So if we do the law of math and apply some of the averages that we know, an average hospital will spend somewhere around $40 million in supply costs. That's taking the averages, the smallest of the smallest to the largest of the largest. If we went systematically in larger numbers, I think the industry reported in 2023 it was around $147 billion were spent in medical supplies. So about 40 million on average, but when you look at it across the country and you really aggregate that number, it's about $147 billion. So that's the spend. What we know is the industry currently is reporting an average of about 8.99% of that gets wasted, meaning it's procured and never used. So just on the raw numbers, there's probably as much as, 13 or so billion dollars a year that is being wasted across the entire healthcare industry today in hospitals. So I'm not even we're talking about hospitals. I'm not even thinking about where we have other opportunities, where we have medical supplies that are being purchased and consumed, but just in the hospital space. So it's a huge, huge number, and it definitely has a lot of opportunity for us to get after in order to use those dollars way more effective than just wasting.
So roughly 9% per hospital.
Roughly 9%. Some are better than others, but others can be a lot worse, right?
I remember, I think it was Susie Collins did a greatest, graphic for me. She had the waste, just the paper inserts that are in implants and things that are the instructions that are never read in about 15 different languages or whatever. And in one day's period, as I recall, she took them all and she put them on a pickleball court. And it essentially filled up about 80 or 90% of one pickleball court in one hospital in one day. And that's just paper. I mean, that's not what we're really talking about in the implants and things, but just that alone, I thought was just kind of outstandingly amazing and wasteful.
It is. And you speak about ORs. In ORs, I think, Steve Downing actually quoted this. The best hospitals will have approximately 10% waste in an OR. On average, it's probably somewhere in the 10 to 15%. So ORs are definitely a big driver of waste in both the dollars, but also, to your point, a lot of the supplies that are used in ORs have a lot of true packaging and other things that are encompassed in what you would consider to be waste.
Christina, well, first of all, I just want to know that anytime Hayes wants a challenge on pickleball court, I will absolutely smoke him 100% when he's ready. He may be 6'6". His voice sounds like he's 7'2". My wingspan's about 7'2". So I'm going to challenge him officially to the pickleball court when we do meet.
But you got me about 150 pounds. I mean, listen, don't.
Hey, I'm not even going to go there, Hayes. I'm going to leave it alone, my brother.
That'd probably be wise. That'd be wise.
All good. But the pickleball court is open. But hey, Christina, we are, we're going towards the end of the year where annual inventory counts are really important in resetting and trying to get a number that's valid, whether you're on a periodic, perpetual inventory, or whatever it looks like. These, they're doing what they can to counting the millions of dollars that they have. My question to you, and as I remember even on an implementation, is how do we work with the vendors when we see expiring product or even unused product hasn't turned. What are some maybe some best practices or what you've seen to, are vendors willing to work with us to go back and take it back and say reset and give credit? As long as it's not unopened, as long as it's not a custom pack, those kinds of situations. What are you seeing on some of those support of that bottom line to help with some of those hospitals?
Yeah, that's a big one. And I will tell you that vendors are willing to work with customers around some of those situations. But what I will also say is it comes with a caveat, which is they need to have enough time and enough advance notice that they can resurface and recycle that product within their own customer base and supply chain. So you can't call your vendor the day after it expired, or call your vendor when there's only 24 hours or 48 hours of life left into the product before asking, hey, can I swap this out for the same thing, or can I swap it for a like product? Yet, if you have visibility and easily can get access to the visibility to know what you have on hand will expire in some amount of time, whether it's, and vendors are different depending on the product line and their ability to reuse or, reallocate that product elsewhere. It may be 90 days, it may be 180 days, but if you can, call your rep and say, I've got these 3 products that have 180 days worth of use. I know I'm likely not going to use them. Can we swap them out? They are, I think, far more willing to do that. It's a collaboration at that point and allows them to not waste something that could be used. And so, yeah, definitely, I think that is a conversation that's happening more and more.
That's great. I just think about the reverse from your DC, your distribution center. You have all these inventory levels and min-maxes that are feeding a hospital system, a public health district, whatever it looks like. It's like, how do you reverse that back and not affect that? Because I think there's downstream, but there's upstream effect too. So that continual vendor communication, I think, is just key, right? Just having that conversation.
Yep. That's one of the things that I think is really important when we talk about waste, but we talk about just the efficiencies that we can gain as a healthcare industry is, we like to say this a lot on the clinical side, which is giving our clinicians back the time to operate at the highest of their licensure so that they're doing the tasks that are taking care of patients. But we have the same opportunity in supply chain, which is giving our teams the ability to operate at the highest skill set they possibly can. So if we can be more collaborative and use data and analytics and things like that to allow people to solve problems in a proactive way, then people are making some really, I think, improvements in the way that we're able to work together. If all we're doing is leveraging our vendor partner reps to put out fires, then they're not really able to help us in the most meaningful way. So, that's definitely, I think we should take that learning from the clinical space and apply it to the supply chain space too.
That brings me to PPI, which you alluded to in your 3 categories, those physicians' preference items. And you're just talking about being proactive about that. But to your point, there are a lot of unique supplies that might be very surgeon or, a couple of surgeon specific, but we're not always that proactive in sort of knowing when maybe they're not going to do a certain case that doesn't need that anymore, or they're moving to another organization, right? And then that leads to some of that waste. Like, what are some best practices in kind of managing that, especially because it seems to me like the fix is a lot more around communication and anticipating sort of the dynamic changes that are going to happen to your supplies.
Yeah, that's a great point. And I would say it probably comes in 2 forms and fashions. And the first is the communication. So, we've been using the terminology of clinically integrated supply chain. And a clinically integrated supply chain is not just a technology that is tying together when products are used on a patient to how inventory is managed, but it's really opening up the line of communication between the 2 disciplines of your clinical staff and your supply chain teams so that when something's happening. And that's not always a technology that is doing that for you. You need to have relationships and open communication to know when things are changing. You have new practitioners, you have practitioners that are retiring or leaving. That definitely is the communication path in a less formal way. I think the other thing is the data, is the transparency of the data. And so being able to make data-driven decisions and work together with your supply chain team and your clinical teams to evaluate what is actually being used, where it's actually being used, and determine if those products are something that you should continue to stock and at what levels they need to be replenished, PARs, et cetera. That's something that is also important. So you've got to have the relationship and communication, but you also need to have data in order to make some transparent and very data-driven decisions. Touching on that, I'd also add, Hayes, I heard this week when we were in Nashville. We were asking a lot of questions about data and the maturity of supply chain teams when it comes to data analysis. Like, there are a couple of things that we heard multiple times. A couple of people said, we're very data rich, but we're information poor. So we have a lot of systems that are driving a lot of data, but we don't have either the skill sets to pull analytics out of that, or we're not sure how to tie our systems together in a way that allows us to do that. So that's one thing we heard. And then the other thing that we heard, I thought, was, it's not novel. I think I've definitely seen this with our customers, but I haven't heard it so explicitly stated, which is value analysis teams, which is extremely important. And, your point there with PPI and knowing when and how to manage physician preference items, a lot of that goes through a value analysis process. But recently what we're hearing is value analysis is not being leveraged in the way that it should be to truly understand how product can and should be used. It's being leveraged as a new product approval board. And so there is no true value analysis of decisions that we made previously to ensure that we need to continue in a certain way. It's just, what's the newest product that I want our facility to carry so I can use it? I'm going to take it to my value analysis team for approval and move on.
I feel like that mirrors kind of the traditional structure of procurement in so many ways, right? Is because typically it's how do these products get in the door? But then once that happens, how do we really monitor and optimize in general? So do you find it surprising that that's what's happening with value analysis, or do you kind of think that they come by it pretty honestly?
I think they come by it pretty honestly, but I think that what it's indicative of is the ability to have access to actionable and transparent data. I think in the absence of that, you have to rely on the experts. And in healthcare, the person who is performing your surgery, my surgery, or any loved one surgery is the expert in the room. But when we have data and we have the ability to share that data in a transparent way, then we can collectively work together to make appropriate decisions for the health system, as well as, and that's at the top of that is always patient safety and patient outcomes. But then there's other things that need to factor into it.
Last week's episode was with Melanie Perry, who's the co-host of the First Case podcast, which is our sister podcast for the operating room, and really ties in greatly to what you were just talking about, that focus on not only elevating those within supply chain to perform at the top of their license, but also nursing, right? Or their top of their capability. And she talked a lot about that, but do you want to expand? You just kind of talked about, patient safety, but how do these optimizations, how does looking at value analysis, after the actual, product approval stage help with improvement in patient care and patient safety overall? Are there some, and maybe even if you have a story to kind of illuminate this one, that'd be great too.
Yeah, I'll think about a story as I kind of kick off. In the value analysis process, and this is a super basic example, and this actually is a true story. We were working with a customer and we were setting up a supply room. This is a general supply room in a nursing unit, so it's not in the OR. And as we're helping them set up, where supplies are going to live to make them easier for nurses to come in and grab exactly what they need to take care of a patient, know where it's at, et cetera, we started evaluating a list of products that we were tasked to set up for inventory management. And there were literally, I think, 5 different types of soap. There was a little tiny travel size bar. There was a full size bar of soap. There was a liquid soap. There was something free soap. There was 5 different types of soap. And you have to ask yourself, and this isn't a patient's, I'll use this basic example, but you can apply it to those same items that have a lot of impact on patients and are very complex to use. But you take 5 different types of soap and ask yourself, why do I need 5 different types of soap to take care of this patient? And how many different ways does my clinical team need to know how to use that product in order to use the one that they're picking up specifically the way it's intended to? Now you take that and you apply it to something very complex, whether it's even on something as a needle, and think about all of the clinical training that has to go into all the different types of needles that nurses will interact with taking care of patients. If you don't have to, if you know that there are 3 ways that I'm going to use something, and every time it's the one of 3 ways, you can train a lot easier. You can learn a lot faster. You can standardize in that way. And I think that's the thing around value analysis. We keep adding new products, but we're also not evaluating what products are, therapeutic equivalents in that same class. And is there a true need to have all of that variation? Or do we have some opportunity to reduce variation? I'm not saying that one thing is going to solve everything, but there is an optimized variation that really does have an impact on patient care when the clinical teams can get really crisp and clear and very standard on what they're interacting with to take care of patients.
That's a good example, actually. The soap. I've heard there's a guy years ago, I overheard him talking about they had to have 3 different types of straws per floor, or on each floor had 3 different straws. And it's like, it's a straw. He goes, well, one's bendy, one's this and that, one's, so to your point, they add them, but they never remove them. So their SKUs just get bigger and bigger, unfortunately.
I love the clinical analogy too, though, because I'm not sure it's always, sort of marketed internally about what you're trying to accomplish to make things easier operationally when you're doing, supply optimization that way and SKU reduction. Because, and I am a clinician, right? My background's as a nurse. So like you start telling them that you're taking things away, that's a whole different experience than saying, we want to make it easier for all of the clinicians on the team to know exactly how to do best practice. And when you figure all the turnover that's going on in healthcare, especially around nursing with so many that are now hitting retirement age and the shortages, you have a lot of newer nurses coming into the field. And I think accomplishing, streamlining what they're going to be trained on and increasing proficiency. That I hadn't even thought about, to be honest with you. As in terms of impact in other areas, Hayes kind of talked about the pickleball court and how Susie accumulated all of that paper. So I now want to move into sort of environmental consequences and sustainability. And that's a great example, is all the paper that's being, used when the IFUs are being sent out with the products and things like that. But obviously, if we're throwing stuff away, that is also having an impact on the environment. So do you want to kind of expand on that area of waste for us?
Sure. And I will tell you that, initiatives around sustainability and environmental impact are really elevating in our space of healthcare as, everyone takes acknowledgement that we're one of the biggest offenders in just landfill space, right, with medical waste. So it definitely is becoming a priority. We have a couple of, I'd say, advanced health systems that are looking now in ways to measure their CO2 footprint. And we're helping them through some of that data transparency. So you can't set a baseline or you can't set a target for something that you can't measure. So when you're able to measure what you are throwing away, then you have more opportunity to understand where are you today and where do you have the prioritization to work on efforts that will get you to an improved outcome. I heard someone actually, again, Hayes, you're in front of my mind as we were just having these conversations last week. We asked questions about this as well. And I think there's also, something to be noted that as our industry advances and evolves and we have younger individuals who are coming into the workforce, they tend to be more aware of the environmental impact that we're making across the entire continuum of all things in our lives. One individual said, I have young people coming out of college joining our team, and one of the first questions they ask me, which surprises me every time, is, why are we still using styrofoam cups? So, we definitely have an opportunity. And I know that as we think differently as a society about the environment and how to sustain the environment, it will become even more important and even more impactful in how we approach that. So today's technology, your example is fantastic, Hayes, with setting out all of those pamphlets. We have a lot of opportunities to use all the devices that are in our hands all the time to scan the QR code and quickly be able to read and even search for a specific word or phrase that we need to understand better if that's what we're looking for, versus opening up a 3x3 pamphlet that's in basically a 5-point font that none of us can read it, and then try to find what it is that we're looking for. So, I think it's definitely on the edge and coming up with more influence and prioritization in the future.
I think it's important. And to your point, you can't read them anyway, and there are 15 different languages. However, I think that they are required. So someone's going to have to change the policies out there to say, yeah, you can use a QR code rather than include the paper and the printing and all that other stuff. So it would save time and money, I think, instantly. So hopefully that'll happen soon.
Oh, and just imagine this. Imagine how many times that our manufacturers need to update some small portion of that pamphlet.
Yes.
Right? And now it requires them to reprint, reattach, probably change their barcode, which our hospitals are using for patient documentation. And now they have a new barcode that just entered into their entire data system that they've never seen before. So it's just it's a perpetuation of, we've got to get smarter, faster about how we approach some of the issues and the challenges.
It's funny because it's something that I had really thought about when UDI was coming into play back in, 2012, and those conversations were really starting to happen. I was like, this is a great place for the instructions for use to live in some way, or even if it's just a link, because of what you just said, the changes that come up all the time. Because in that time frame in 2012, I was supporting sterile processing. And so the instructions for use and how to clean the instruments, that are reusable before they go back into the OR, and the turnover that happens in that department. And typically, there are some electronic solutions at the time that were out there, but they were more of a document repository. There was really no responsibility except on the manufacturer to try to update that. A lot has changed since then, but it's a great point that you're making is also, what about relevant information? If it's 20 pages and you're in decontamination, you don't need to kind of take your PPE off and go over to an office and try to look through all of that. If you could simply, search in that PDF document, that's electronic, to figure out exactly what you need for decon, that really has some major operational efficiencies, I think, that can be built into the leveraging of that technology for sure. All right, we're getting really close on time. I had a feeling this might happen where, we would really be flying right through the interview, and you've added, quite a lot of good info. And I like your analogy there just a few minutes ago, but let's focus on strategies, maybe in the last 5 minutes here, some real takeaways that can help people reduce waste. And also, I think what you've been talking about is allocating resources, right? Whether that's human resources or supply resources, but, using them more efficiently to help reduce waste. Can you maybe give us a few strategies that everybody that's listening can take with them following the interview?
Absolutely. I think the biggest and most effective strategy to reducing waste is having visibility to data and having visibility to know what is actually being used across your health system. If you know what is actually being used, then you have a lot more opportunity to know exactly what it is that you need to stock, where you need to stock it, and when you need to stock it. So the biggest thing there is the more visibility you have, the more opportunities you have to make better decisions on par levels, on location of product, on forecasting. I mean, we talk about patient safety, and our minds often go to the strategy of reducing expiration. So, how do I reduce my expiration? Because that's a waste component. There's another component, I think, here around when we talk about data that's indicative of waste, but it's a little bit of the opposite, which is making sure from a patient safety aspect that you have what you need where you need it. It's just as bad to not have a product when you need it as it is to have something that doesn't need to be there. So, that's, another thing around data and making sure that we have what we need, where we need it, when we need it. So data would be the first thing. I think the second thing is we've touched on is with that data is now using it to really build some stronger relationships and have more transparent and data-driven conversations between your teams. And it goes even further when we start talking about data. We're talking about waste today, but how do I reduce the waste, and how do I work with my clinicians to know what it is that they need and make sure that inventory is in that right place when they need it? there's other teams that benefit from the conversations that you're having, whether that's sourcing, it's clinical education. It's also, your logistics team. There's a lot of areas that we pocket information today, but being more holistic in how we view that data and bringing other individuals into the conversation has a lot of value as well. And then I guess, thirdly, and you asked us in the beginning was, I think, Gary, how do we work with our partners in our vendor space? And I think that hinging on data, we have opportunities to open up conversations that we haven't had in the past to make sure that we're providing as a healthcare provider, we're giving our vendors the right information so that they can forecast and manufacture what is needed in appropriate levels in the right time. And they can help us better, manage our inventories as well. So again, I think 3 different little, slices of flavor there, but really all is foundational on having visibility to data and giving that enterprise visibility across the board.
Yeah, that forecasting piece, so elusive for healthcare organizations today, and how do they get that over to manufacturers? Because honestly, if the manufacturers are playing a guessing game and they're doing manufacturing runs and they wind up overproducing in one area, that can actually wind up resulting in an inability to keep up in another area. And so you do hear a lot more conversation around that than you used to in the past, when it seemed like we had unlimited budgets to support the clinicians and we had unlimited supply of resources in manufacturing. And we know that neither is true 20 years later as we kind of sit here today and try to reinvent healthcare.
No, absolutely.
I was just going to add, MD Anderson is doing some obviously are very interesting things around demand forecasting out to 18 months on cancer. Michael Prokopis talked about it at our meeting, and that literally they're starting to forecast out to MSAs and or even zip codes to say, we know how many are going to come in from this zip code. Therefore, we're going to need X product or whatever. And so it's fascinating. And so ultimately they're going to try to partner with their companies, their vendors they need, and have the right product in the pipeline and ready. So things like that are obviously, we need them. But I thought it was fascinating that you could even dream about doing that with like cancer, for instance.
Yeah. And you're 100% right. When we talk about OR scheduling, we can receive OR schedules up to 30, 60, 90 days in advance. You're scheduling, a knee replacement or whatever that may be. And a lot of our hospital partners tell us, well, 30% of my cases coming in my OR are not scheduled within 48 hours. And that's true. But if you use the data and the analytics we have and the tools of today, you have enough information and data to be very predictive about what you will see in that 30% that is not scheduled. And so we have working with customers and partnering with customers to be able to do that, to say, you generally are probably going to see, how many car wrecks. It's the winter time. You're going to have falls. It's sports time. You're going to have, these types of injuries. And there is some predictability in those models that we can get better at, that help drive better decisions.
All right, Christina, this was a great interview. I want to thank you so much for coming on the show. And anything you want to add before we wrap up? Although that sounded like a really great close a minute ago.
I could talk about this all day long. I could go on and on and on, and we could change topics and spin around 1,000 different ways. But I appreciate the opportunity to have these conversations. I always learn something and appreciate the thinking and how everyone is really starting to move in a different direction and be more proactive with it. So thank you.
That was Christina Tosto, Vice President and General Manager for WaveMark Clinical Supply Chain Solutions at Cardinal Health, talking about the impact of medical supply waste on patient care, the costs, obviously, for hospitals and healthcare organizations around the country, but also performance. And I think the thing that really stuck out to me, Hayes, was just the ways that, hey, if we can standardize products, we can also standardize and reduce variation on nurse training. And I think that is maybe an undervalued or at least under-recognized plus, and should always kind of lead the way whenever you're trying to do any optimization and reaching out to clinicians. Because I hadn't really thought about it, but they're typically going to view it as you're taking something away from me instead of bringing value to our department.
Nobody likes to be told you cannot have this anymore. Nobody. Yeah. And so you can imagine the problems that would create. But she highlighted several things that were kind of no-brainers in the way I look at things. So she really brought her expertise, and I learned a lot from her. It was really well done.
Yeah, so much of it is a no-brainer, but it's like putting it into action. Like she was saying, we have like a lot of data, but we haven't really necessarily been able to take that data and make it useful and actionable. And I know a lot of our conversations on this show have centered around that. And so you can tell that she's been immersed in it for 17 years. She was an absolute fantastic guest. And for all of you out there, make sure you're following Power Supply on social media. If you're listening to any of these episodes and you have feedback or you want to comment on a post on LinkedIn, I definitely want to encourage you to do so. And on behalf of Gary, who ducked out a little bit there towards the end, got pulled into something, and Hayes and myself, thank you for listening to this episode of
Power Supply. Bam!
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.